I know there's still some folks in the kitchen, so come on in. We're going to start today's program for you all in the room and for the hundreds of folks that are joining us virtually through a live webcast. We're really pleased today to release the 7th annual PCPCC evidence report. And let me introduce Darrell Moyer, who's going to open the program. Her extensive and impressive bio is in your packet, but so that you know, she's Executive Vice President and CEO of the American College of Physicians. She has got a very important leadership role in medicine and continues to practice. So she has direct interaction with patients, which gives her lots of insights in her policy role. Thank you.
Thank you, Anne. So welcome to the release of the 2018 Patient-Centered Primary Care Collaborative Evidence Report. I am Dr. Darrell Moyer, CEO and Executive Vice President of the American College of Physicians, and I'm also Vice Chair of the PCPCC Board of Directors. As Anne noted, I'm also a practicing internist. I'm now a PGY 34. I know you find that hard to believe. And I help to care for some of the most vulnerable patients in a Philadelphia area-based patient-centered medical home. And anyone who knows me recognizes that I like to keep the focus, the policy focus, what we do, and to keep that focus on the patients that we care for. Primary care is foundational and so much more. In the course of the day, we'll care for patients with a single problem to a multitude of medically complex patients. People also who know me know that my nickname when I walk into the practice is, oh boy, here she comes, Dr. Darrell Call 911 Moyer. And on a recent occasion, demonstrating that what we do is so foundational and so important and so varied, is that I got the phone call as I was sitting there with the brand new interns on their first day of their internship in late June. Phone call came from the reception desk, and the reception person said, oh my goodness, Dr. Moyer, you need to get out here. We have a patient that's collapsed on the floor. And as the interns watched us work through a rapid response to care for this patient, who I'm happy to say fared very well, we really reinforced that primary care is so foundational, and we do so much in this world, everything from those simple single issues for patients to literally saving their lives in our practices. So I'm very pleased to welcome you to the briefing at the PCPCC's offices. I'd like to also welcome those that are watching via live webcast. As many of you know, PCPCC is a nonpartisan, membership-based, nonprofit focused on making primary care more patient-centered and more robust through policy and advocacy efforts. With us today, we have a diverse set of public and private policymakers and members of the news media. Before we begin, I would like to thank our sponsors, NCQA, American Academy of Family Physicians, Anthem, IBM, and the Pacific Business Group on Health, who made this briefing possible. I would also like to recognize and provide a big shout out to the Milbank Memorial Fund, who has tirelessly funded PCPCC's reports year after year, and IBM Watson Health. Both of these organizations have generously supported this year's report, and it would not have been possible to do this research without them. So thank you very much. This occasion marks the 7th release of the annual PCPCC evidence report, underscoring the PCPCC's strong commitment to gathering, synthesizing, and disseminating evidence related to advanced primary care, including the patient-centered medical home PCMH model. This report builds on the past work, but goes beyond it to examine, through both qualitative and quantitative methods, how the PCMH interacts with the broader medical neighborhood, and in particular with accountable care organizations, ACOs. Similar to PCMHs, ACOs have grown rapidly over the last decade within both the public and private sectors and hold out the promise of better population health at lower costs. In the Medicare ACO program, they have enhanced quality, yet only 1/3 have reduced cost after accounting for federal investment. The PCPCC, under the leadership of its president and CEO, Ann Greiner, wanted to know if a foundation of advanced primary care, PCMH, was an important contributor to the success of the highest performing ACOs. The PCCC contracted with the Robert Graham Center to answer this research question. Surprisingly, the Robert Graham Center researchers found no existing peer-reviewed articles that examine this question of the relationship between PCMH and successful ACOs beyond a single health system. This report marks the first of its kind. This relationship is important to study to better inform public and private policymakers as they evolve both PCMH and ACO models. Today, you'll be hearing from experts on panels and in the audience who make and shape such policy, and we hope that this report informs their thinking. We also hope that it spurs a lot more research in this area because there are many unanswered questions. My own reflection upon reading this report is how critical a foundation of advanced primary care is achieving the results we desire for patients and for the entire system. It is primary care that can work in partnership with patients to keep them well and, if necessary, help them manage one or more chronic conditions so that they don't end up in the emergency room or being unnecessarily hospitalized or readmitted after hospitalization. We need to invest in primary care for better outcomes for patients and lower costs. The ideal situation is when the larger system in which primary care practices is in sync with respect to mission, performance metrics, and financial incentives to deliver on the promise of improved population health. ACOs hold out that promise, and working together with primary care can really deliver. Now let me introduce the lead investigator of the 2018 PCPCC evidence report, Dr. Yalda Jabapour, medical director at the Robert Graham Center. Dr. Jabapour is a family physician and medical director of the Robert Graham Center. In this role, she oversees the visiting scholars and program and conducts research on high-performing primary care and practice transformation. Dr. Jabapour came to the Robert Graham Center as a Robert L. Phillips Health Policy Fellow in 2015. But before she joins me, let me review the run of the show for today's briefing. After Dr. Jabapour presents the research findings, we will have a diverse panel that considers what the research means for patients and clinicians. Following that panel, public and private leaders will consider the implications on policy. And after that panel, we will open it up for questions. Ann Greiner will provide summary remarks. So please, now let me invite Dr. Jabapour to present her research.
Thank you very much, and thank you all for being here today. As Dr. Moyer mentioned, I'm here to present the research that we did on the intersection between advanced primary care, the patient-centered medical home, and the ACO model. Before I start, I'd really like to thank my co-authors on this report. You can see it was a big group effort to put this report together. I'm the one who's speaking up here talking to you today, but it's really all these people up here that put the report together and helped it come together as it did. And I thought it would be helpful to have some background context on why we decided to take the Patient-Centered Primary Care Collaborative report in a slightly different direction this year. As was mentioned before, every year for the past 7 years, the Patient-Centered Primary Care Collaborative has looked at the literature on the patient-centered medical home and put together an annual evidence review. We were part of this evidence review last year, and we showed, as you can see, that although the patient-centered medical home had generally positive outcomes in terms of cost, quality, and utilization, it wasn't always uniformly so. And there are a few reasons why the patient-centered medical home, as well as it does in providing quality care, may not be meeting its full potential. One of these is that we tend to underspend on primary care. And if we want an initiative to make a big dent in the cost curve, it's hard to expect that to come from an initiative that's based solely in primary care. Secondly, primary care works in a much bigger ecosystem of specialists, of hospitals, of long-term care facilities. And if we can't incentivize people, care facilities and providers along this spectrum of care to improve quality and reduce cost, it's going to be hard to see any kind of big impact in terms of quality and utilization. So in comes the ACO model. Accountable care organizations have promised to link these differing spectrum of providers from primary care to specialists to hospitals and incentivize them to lower the cost of care for their patients and also improve quality of care. This data that we show up here is taken from the Office of the Inspector General report that was published in 2017. They analyzed the Medicare Shared Savings Program, which is the largest Medicare Accountable Care Organization program. And as you can see up here, in terms of quality, these programs actually did pretty well. They improved their performance on about 82% of the measures that were studied, and they outperformed fee-for-service on 81% of measures. And the graph shows that there is some variation into how these ACOs performed, but from 2014 to 2015, a greater proportion of them actually had quality scores above 90. The OIG report also looked at the shared savings generated by the MSSP ACO program. Medicare sets a benchmark for each ACO, and if the ACO spends under the benchmark, they receive a portion of that shared savings. In the years that were studied, 2013, 2014, and 2015, only about 1/3 of the ACOs received a portion of the shared savings. This graphic shows that there was also variation in ACOs spending below their benchmark and above their benchmark, but there was a net spending reduction of about $1 billion in the 3 years studied overall. Interestingly, half of these spending reductions were generated by only 36 ACOs, which begs the question of what are these high-performing ACOs doing differently? And in the OIG report, they mentioned a few things. One was the ACOs that reduced spending tended to reduce spending mostly in the inpatient facilities. SNF, skilled nursing home facilities, home health, durable medical equipment, and hospice followed after that in terms of reduced spending. High-performing ACOs were more likely to include physicians only as opposed to being hospital-led. High-performing ACOs had sicker patients, more multimorbidity, and really where it applies to us, high-performing ACOs had the highest number of primary care physician visits, really going back to the fact that there is something that we are doing in primary care that is helping these ACOs perform. So that's what led us to our question this year, which was really what is the intersection or the impact of advanced primary care models such as the PCMH on accountable care organizations. And as was mentioned, different from the past, we didn't just do a literature review. We did a literature review, we had an expert convening, and we also did our own quantitative analysis. Section 1 of the report is a literature review, and it's a broad literature review looking at characteristics of successful ACOs. In this part, we were not preoccupied with whether those ACOs were based on an advanced primary care foundation. We wanted to look at successful ACOs overall and find out what they were doing differently. We defined success as ACOs that had shared savings, reduced spending, or improved quality of care. Section 2 was getting closer to our main question. We were looking at the impact of those ACOs who were based in advanced primary care on cost, quality, and utilization of their system. We defined advanced primary care as those primary care organizations that closely aligned with the shared principles of primary care. And I'm sure Anne will touch on this, but just briefly, because I talk about the shared principles throughout this presentation, the shared principles are an ideal vision of how advanced primary care should be delivered. They were created by a diverse and broad group of community partners and released in 2017. So in our report, when we refer to advanced primary care, we're referring to those primary care organizations that closely align with the shared principles. And then the third section is really our own quantitative analysis done at the Graham Center. It was what we were hoping to find in the literature but couldn't, which is cross-referencing NCQA patient-centered medical home data with the Medicare Shared Savings Program data to look at the impact on cost, quality, and utilization. I show you this not because I want to go through the entire literature review in detail here. The methods are all in our report, but essentially we use the help of library scientists and key informants to come up with a series of search terms for our first literature review. And then we found through a very rigorous process using inclusion and exclusion criteria, which are all outlined in the report, that there were 15 articles that really met our needs. We then thematically analyzed these 15 articles and found that these 6 themes kept coming across as key contributors to the success of an ACO. And you'll see this graphic is also in the report. The numbers stand for how many articles mentioned those themes. So number 1, engaged leadership was important. Engaged leadership and a culture that was ready for change and team-based. Experience was important. Experience with prior practice transformation. Robust health IT system was important. Effective care management was important. So not just any care management, but highly effective care management. Environmental factors was a combination of things such as rurality, but most importantly, people kept mentioning how important the benchmark was for success. And then payer alignment, both in measures and payment, was found to be important. We heard these same themes echoed over and over again in the expert convening that we held at the Robert Graham Center. And this is a list of participants that were at the convening. As you can see, it was a very broad, diverse group of ACO leaders, researchers, physicians within an ACO, and patients even within an ACO. And our conclusion of this first section is that those characteristics that we had looked at that were highly attributed to success in an ACO aligned very closely with the shared principles of primary care. And this graphic is also in the report, but I just put it up here to demonstrate the alignment on the left, which were the characteristics that we found, with the shared principles on the right. Our second section was also a literature review, this time honing in on those ACOs that had an advanced primary care foundation. It did not matter to us whether they were physician-led, hospital-led, who was on their governing board. It was more important that somewhere in the article or something about the organization made it based on an advanced primary care model. And in our appendix, you'll find where we detail why we thought they were an advanced primary care model. So once again, we used a rigorous search criteria, and we were able to find 10 articles that helped us answer these questions. In terms of cost, the articles showed generally positive results. In terms of quality, all the advanced primary care-based ACOs had improvements in quality. In terms of utilization, just like last year, we looked at primary care utilization, ED utilization, and inpatient utilization. We considered something positive if it had an increase in primary care utilization, if that then led to a decrease in inpatient and ED utilization. Those results were a little bit more mixed, but we have to take this all with a grain of salt because this was just 10 articles that we found. 8 of those articles were based on evaluations of individual systems. Only one of those 8 looked at the exact question we wanted, which is within an ACO, within a particular ACO, how were the PCMH-based clinics doing compared to the non-PCMH-based clinics? There were 2 cross-sectional studies looking at the Medicare Shared Savings Program. These looked at the impact of primary care, not necessarily advanced primary care. So this dearth of studies led us to our third section, which was our original quantitative analysis. And in this section, we really wanted to answer the question of, do ACOs with a higher share of advanced primary care models, such as the PCMH, perform better? We used NCQA PCMH accreditation data as a proxy for advanced primary care because they have a very large share of accreditation of the patient-centered medical homes. And then we use the 2014 Medicare Shared Savings Program data, which has cost and quality results. Our outcomes were to look at the differences in shared savings and also quality measures. We took each ACO, and with the NCQA data, we were able to find the share of primary care physicians that were PCMH certified. We then divided those ACOs into quartiles, with quartile 1 having the lowest share of primary care physicians who were NCQA PCMH certified, and quartile 4 having the highest share. On average, quartile 4 had about 42.6% of their primary care physicians who were PCMH certified. We compared everything to quartile 1, where there were no PCMH providers. We adjusted for practice and patient characteristics, and we also adjusted for the benchmark. In terms of quality, we looked at all the quality results that were shared by the MSSP data. We found statistically significant improvements in terms of these quality measures listed here in those ACOs that had a higher PCMH share. Table 3 in the report goes through all the quality measures, and you'll see generally very positive findings. These were the ones that had statistical significance. And important here is that the 2 composite measures we used that were a combination of individual measures, the diabetes measure and the coronary artery disease measure, both showed statistically significant improvements as you moved up the share of PCP PCMH. And these are the shared savings results. So once again, we're comparing to quartile 1. And you can see here that quartile 2 and quartile 3 had increased percentage of savings as compared to quartile 1. Specifically, quartile 2 had a 1.6% higher shared savings rate than quartile 1, and quartile 3 had a 1.3 higher savings rate than quartile 1. And 1.6%, 1.3% might not seem like a huge number in magnitude, but if you look at the dotted line there, that's the mean savings rate for the ACO program in general, and that was 0.6%. So in conclusion, our literature review showed that the characteristics that were associated with success for ACOs were highly aligned with the shared principles. And also, ACOs with a strong advanced primary care foundation had generally positive cost outcomes, positive quality outcomes, and mixed utilization outcomes. And our Section 3, our original quantitative analysis, showed that Medicare ACOs with a higher proportion of PCMH primary care physicians were not only more likely to generate savings, but they demonstrated higher quality scores on a significant number of process and outcome measures. So that was a very quick overview of a very comprehensive report. I'll make sure to stick around afterwards if anyone has any questions, or if you'd rather email me, please feel free to do so, and I will make sure to get you the answer. Thank you very much.
Okay, so welcoming panelists up, Bill and Rob and Ann. And while they are getting situated, let me just do some very brief introductions, because as you can see, we've got a jam-packed program. So let me start with Anne. She is an internist. She is from Community Catalyst, and she is the director in a really interesting center. It's the Center for Consumer Engagement and Health Innovation. So Community Catalyst is really trying to bring the patient perspective and voice into health system transformation, a voice that is often really not considered, and we applaud you for that work. Anne was, prior to joining Community Catalyst, Director of Health Policy and Strategy for the Commonwealth of Massachusetts. Welcome. Bill Kassler, to Anne's right, is Deputy Chief Health Officer and Lead Population Health Officer at IBM Watson Health. Interesting to note, he's not the Deputy Chief CMO, but he's the Deputy Chief Health Officer and Pop Health Officer. So we're really excited to see that emphasis at IBM Watson Health. Prior to that, he was Chief Medical Officer for the New England Region Centers for Medicare and Medicaid Services. He's also worked at the state level as a health officer and medical director in New Hampshire. We're thrilled to have you here today, Bill. Thank you. And then finally, Rob Mechanic, someone who you may know in his role at the Heller School at Brandeis, where he's a senior fellow. Most recently joined as executive director of the Institute for Accountable Care, which is an organization that is separate from but associated with, and I hope I got that right, Rob, the National Association of ACOs. And so I think ACOs have understood that there really needs to be more focused research on that particular care model and have set up this institute. We're very excited to have you here today. So let me start with some questions for Anne, if I can find my... really, as you think about these results, Anne, I'd be curious what you think they mean for patients and families, particularly the quality and cost results.
Sure. So thank you so much for including me here today. Our organization, as Anne said, is really focused on how to build the engagement of consumers, patients, families, caregivers in the design of exactly these kinds of models, and that's something that has been sorely lacking. I am thrilled to see the focus on primary care, not just because I'm also a primary care physician, but because primary care is the main point of contact for most people with the healthcare system. And that's, when you look at the ecology of healthcare, where healthcare is delivered, that has remained true for many decades. We've certainly done a lot of work working with consumers, particularly those with complex needs. And when we've done focus groups with consumers, one of the issues that comes up time and time again is the issue of care coordination, having a single point of contact, having a champion, someone who can help you navigate the system. And I think models of care that really emphasize that fact or emphasize that aspect of care are incredibly important. I will say, I think it's very promising to look at some of the areas where there's improvements in quality. I do think, measurement of quality and looking at the things that matter to consumers is really important. I'm not sure that in the 33, measures that are laid out that we've fully achieved that, but that's something that we'd certainly, be looking for in assessing these models of care over time.
Thanks so much. Rob, you deal with a lot with providers and in your role as a policy person, but also as a researcher. What would you advise primary care physicians and primary care clinicians when they are considering joining an ACO or forming an ACO given these results?
Yeah, okay. Thank you, Anne. Thanks for having me here. So I would say, this was a great report, and I think it shows what many of us already know, which is that ACOs and patient-centered medical homes are essentially cut out of the same cloth. They're very, very well aligned. And, they're aligned really, I think, in their main purposes, which is, number one, to take better care of patients. Number two, to make physicians' lives easier, particularly primary care physicians, who have, a very difficult job. And so if ACOs can do that, it's really important. And then the third is hopefully save a little bit of money in the end. One thing I will point out, so the news on ACO savings has not been all that good. But I also want to point out that, our view at the Institute is that the way that CMS measures the savings is flawed. There have been, coming out in the next couple of months, there are going to be 2 separate reports using more advanced statistical methods that show savings quite a bit higher than what's been reported by CMS. And there's already data in the literature from Harvard and other places showing the same thing. If you use different, more advanced statistical methods, you do see savings and more savings from ACOs. So what should physicians think about when they're doing this? I think there's really 3 or 4 things that the ACOs can provide to primary care providers. One is they can provide more practice support. Oftentimes, ACOs are bigger. They can pool resources, so they can support analytics. They can support personnel to do care management. They can be more supportive with doing referrals. The second thing is they can provide new services for patients that maybe primary care practices on their own couldn't do. So, I talk to ACOs all the time, and, I hear these great examples. So a gentleman I was talking to yesterday said, we've hired 50, this is a big ACO, but 50 community health workers, and these folks go out, visit people in their homes. They do what they call kitchen table med rec, so they actually pour all the medicines out on the table. They write them down. They bring them back to the practices, and if they need to make adjustments, a pharmacy calls. They actually go in and they help people sign up for programs that are available in the community, for transportation, for food, legal services, other things like that. So really taking a full measure of people's lives and providing help in other areas beside direct medical care. And that's something that's hard for a smaller primary care practice to do. Another area
Can I ask
is...
a question about that,
Yeah,
just
sure.
in way of interaction? So where did these community health workers reside, and who has supported their work?
They reside out in the community, so they're employees of this particular health system. They're recruited, they get training. They all have a set of managers and who are linked to clinicians that they deal with, but they basically work out of their home. And really what they're doing is they're driving around, they're going to people's houses, they're going to senior housing, they're going to community centers, they're, a range of places. This particular group is focused primarily on people who have social determinants issues, Medicaid, and so forth. So, but they are, they're supported, they're salaried employees of the health system.
I mean, you guys should feel free to join in this conversation, so it doesn't need to be a one-on-one way. So if you've got questions.
Yeah, I'll just say a couple of things. The other thing, everybody talks about MACRA and MIPS, and I think one thing that's underappreciated is if you are part of an ACO, even an MSSP ACO, you have much lower reporting burdens to the government to comply with the program, number one. And number two, you actually have an easier path to higher scores on quality. So that can be an advantage in that way. And then the last thing is, you're part of a larger organization that is looking to do innovative contracting, and that can get you better contracts in the private sector, not just in the Medicare program. So I think it's a great fit.
Super. Bill, is there anything you want to add as a practicing primary care physician and former CMS official?
So I've had the privilege of being a primary care internist in 2 large health systems in my clinical career at the VA and more recently in a federally qualified health center. And I guess my advice to a primary care clinician is don't do it alone. That there's safety in numbers, that aggregating into large systems is really helpful. But that doesn't necessarily mean that you have to be employed. A wonderful system in my neck of the woods, the Mass Cambridge IPA, has successfully leveraged independent physicians into an IPA that does incredibly well, sharing risk, getting a handle on cost and quality, and interacting with ACOs with a medical home model.
Terrific. Bill, from where you currently sit, you think a lot about data analytics, health information technology, and the LIT review underscores the importance of that for ACOs. What have you seen in terms of the evolution of ACOs or patient-centered medical homes in terms of their use of technology and what's on the horizon?
So before I answer that, I want to thank you for inviting us here. And IBM is very proud to support PCC. We've had a long history of collaboration with the Graham Center, and so it's a pleasure to be here. We understand the value of primary care and health system transformation. So when I look at technology, I see that as an enabling tool to support the key challenges of primary care medical homes operating within ACOs and the clinical team around coordinating complex care, around driving down costs, improving the quality of care, and then helping to offer a better experience of care for patients, for providers, and for family caregivers. And I'd probably like to focus on two of those, both coordinating care and using data for quality improvement. Within care coordination, it's complex. It's why medical homes and ACOs do such a good job. But in order to do that, it's really hard unless you have a good handle on data. So technology can look at a panel of patients or an enrolled group of patients within a system and identify gaps in care, and can target which patients need what sort of interventions to bring them in. We can then stratify patients' needs and interventions based upon segmentation using data. We can help drive assessments that personalize what their needs are and what the interventions are based around technology supporting that. That will then drive care plans. And then implementing care plans require health systems to refer patients to a broader array of community psychosocial support services that are in the community, that are not owned by the health system. And that requires technology, particularly to get that bilateral information flow back and forth. Secondly, I think data is key to quality improvement. Planning at the administrative and management level, using that information to get a good near real-time sense of both cost and quality and how to improve that, and how to drive the QI process. And lastly, I'd say we're not ready yet, but these technologies hold real potential for personalized care and predictive analytics that can help transform at the next level.
Yeah. I mean, I think Bill's company is doing some really fabulously advanced work in analytics, but I think we also have to think about the basics, and a lot of practices don't even have the basics. So, getting claims data so you know where the patients go outside of your practice. And, most physicians don't have that data. You're part of an ACO. The ACO has that data, gives you a real window into your patients. Another thing is, when did they hit the hospital or the emergency department? Hospitals don't call primary care physicians and say, oh, yeah, we just admitted your patient. So a lot of time they come back and, they find out, oh, yeah, we were in the hospital 3 months ago. They didn't know that. ACOs, though, a lot of them, and a big part of ACOs is developing partnerships with hospitals. So if you have a partnership with a hospital, you have a deal, right? You admit our patient, you ping us. We let our primary care know, and then we can, be ready when the discharge comes to ease the care transition to get them back to their office. So there's some very basic things, and believe me, I work with a lot of people who do Medicare claims data. It ain't easy. ACO can bring those analysts that you couldn't hire in a primary care practice. So data and analytics are very important, and it ranges the gamut from very basic to the stuff that Bill's company is doing with AI and so forth.
So first we got to get the blocking and tackling, and then we can get on to the more advanced stuff.
You could do this with a spreadsheet. You can create a registry with a pen and paper, and that's the first step, maybe for a rural New Hampshire practice. But in order to really succeed, I think you have to quickly move to handling that big data.
Yeah, and you need somebody who thinks about it. You need to have a person in the practice. This can't be something that a doc does on their side, because frankly, they got more patients than they can deal with in front of them, and it's getting through the day. So you need somebody else to be paying attention, to be digging in the data, and if you can afford it in a primary care practice, great. It's something you need in ACO.
affording it in a primary care practice, and we'll come back to that. It sounds like a wonderful idea to get the patient voice into these care transformation efforts. Much harder to actually do on the ground. So, how would you use a report like this, or how do you actually try to engage those that are working on system transformation to pay attention to what the patients want and need?
Right. So absolutely. We've spent, with our partner organizations, 6 partner organizations over the past year, we've gone out and talked to 13,000 patients and their families and caregivers, and focusing on patients with complex needs, so low income, people with significant chronic illness, frail elders. And we did that to answer the question, how many people can you actually get interested in this stuff, right? And, we were actually pleasantly surprised that depending on what strategies you used, out of 13,000 people, we got about 3,000 to say, tell me more, and have been working, from that group to develop those leaders, consumers who can come to the table and engage in conversations like these that are not really accessible to a lot of folks. I think we're playing a lot of catch up. A lot of these mock care models, accountable care organizations, even patient-centered medical homes were really designed without a lot of input. And so there's a lot of work to do to build the consumer leadership that's needed to really steer the ship towards models in which consumers have ownership and true investment in. We've certainly worked with healthcare organizations as well to build structures for consumer engagement. It involves a lot of training. It involves a lot of care and feeding and attention. But when it works, it's really quite profound, and it's something we'd love to see more of in the system.
And in your discussions, how do patients respond to this notion of advanced primary care, or what do they think about primary care? I mean, I think, I have 20-somethings, and they're like, why do I have to go into an office for my simple needs? Do I need a primary care person? Couldn't I just go to the specialist? And they're like, they're my children, and they don't get it. So.
I think, Anne, what you're reflecting is I do think there is a lot of stratification, and I think, our organization is particularly focused on people with pretty complex needs. I think what you're reflecting is, I think over time there will probably be more stratification, and not everybody necessarily needs the same system. I think in terms of our work with consumer and community groups, the conversation starts in a different place. It starts from, what does good care look like to you? What are the challenges you've had in getting health care and staying healthy? And it starts from a very different place than, this is the model, what do you think of the model? And so it takes time to make those two lines of dialogue come together and really intersect.
Yeah, I mean, I think also one of the things patients really want is access, and quick access. And that's something that's very hard to do in a small practice when you're, booked up from 8 to 5. I think particularly also with the most complex patients, the most frail patients, access is really how you save money. And, I know of one group that they use some fairly sophisticated technology to stratify their patients. But people who have a risk score above X, the header on their medical record changes color. And that's a signal. It's a signal to the receptionist. It's a signal to the nurse, anybody who interacts with a patient, that this patient deserves special care. And if they say they have a problem, you make space for them right now, today, and get them in here.
And I would say one of the things we say in our office is that primary care is a service, not a building. Right? How do we start to think about primary care as built around patients and communities and what their needs are, rather than you need to come in or you need to come to us as providers to access that care?
Mm-hmm. I'd like to build on your remark about access. I'm thinking back, and it was a number of years ago, to an article that Christine Bechtel and Deborah Ness did, where they did a focus group with patients, and they asked them, what is patient-centered care? And it was all about care coordination, which is, I think, what these models hold out, that somebody would be there to, integrate and coordinate your care, yes, provide you access, but then once you're in, making sure that, you are getting your services coordinated, the general contractor, if you will. And, when we think about what's going on with the health system, it's getting more complicated, not less. So this whole notion of a care coordinator, not the care coordinator, the 5 that might be calling you if you've got a complex condition, but actually someone who you have a personal relationship with that is actually looking out for you. It also seems that the research suggests, and we hear all the time, that that's what people are looking for, no matter really where they are, even if it's sort of someone who is frail, elderly, someone with complex needs, or the 20-something still wants coordination in the system.
Well, Atul Gawande wrote a really nice piece about this and how important it is to have somebody in the system that knows you and knows who you are and knows your history, because they might make very different decisions than somebody who all of a sudden, you're having an issue, they've never seen you before, let's do all the tests.
Right.
Doctor who's been with you for 30 years, oh no, this has happened before, we've seen it before, we don't need to do testing to do it, and you can save the patient a lot of hassle and you can save the system a lot of money. So I think that, someone who knows you, our system that knows you, is a very important piece of the equation.
Agreed, and that is actually what I use with my kids, because I said you went to the same pediatrician for 0 through 18. They really knew you. Now you've got to find someone who's going to be, for that next journey, who is going to know you in a very comprehensive way. And I think pediatricians have done a really good job of that. Now we need to help the rest of the clinicians in the health system to do that same kind of job. Bill, you alluded to some of the new technology, and you talked a little bit about personalized care, but there's also AI, there's also Fitbits and other technology. How's that going to factor in, as we think about patient-centered medical homes, ACOs, and all this new technology?
So I tend to think about AI and big data as going hand in hand. It turns out that each one of us will probably generate 12 terabytes of data, of health-related data, in our lifetime. To put that in context, that's more than the entire written collection in the Library of Congress. So not only is it healthcare data and genomics and other omics data, but it's information on our behaviors. And it's information that are increasingly coming from our wearables, from implantables such as glucose, continuous glucose monitoring for insulin pumps or other implantables in the cardiology space. Much of that data is unstructured. It's in notes and images and whatnot. And machine learning these systems are really, really good at sifting through a tremendous amount of data. Data on the community, data on housing and behavior, and integrating that into the healthcare data and coming up with insights and rendering those insights to us as clinicians in a way that we can interact with it, not necessarily through an EHR system that you have to have multiple clicks, but can take that complexity and visualize it and help us in near real time at the point of care. And I would just sort of say that these systems are early, they're formative, but they're really going to be the future. And the capacities right now in terms of these machine learning systems, in terms of understanding visual and auditory input and making mistakes are getting close to, on single tasks, what we as people do in terms of our error rate. The complexity is sort of putting them together. So they're not plug and play. You can't just go like a computer and put it into an office system. They have to reduce the clinician's burden and fit into the workflow, but they are going to change our workflow, and we cannot take advantage of them unless we think through in a lean engineering sort of a way, what are the ways in which we can best use them, and how do we change our workflow, and how do we do human-centered design and lean production in order to make the best use of those technologies.
I think that is music to a lot of people's ears because they can't imagine one more data flow
Right.
to manage.
Yeah.
Like it's just, it will blow up their heads if they have to do
So I think there's huge potential to sort of solve the EHR conundrum because we're never going to go back to paper. They are incredibly valuable, and yet we know that EHRs, that interface, is just not conducive to a clinician workflow. And so I think interposing machine learning, AI, and some of these technologies, these conversational analytics that can listen and parse out information, that can read volumes of text and synthesize that and put it right in front of our eyeballs. I think that's where the future is.
Terrific.
Yeah, I love the fact, Bill, that you're talking about simplifying the interface, because I think that's one of the key areas of frankly, of burnout of primary care physicians.
Absolutely.
I would say, I'm not sure I want anybody to have 12 terabytes of my data. I don't like Google tracking me on my cell phone, and,
Right.
So I think it's going to be an acquired taste.
So let me thank you for bringing that up.
Yeah.
And one of my former bosses, Don Berwick, at when I was at CMS, said nothing about me without me. It has to be around consent, and it has to be around privacy, and it has to be around data security. Those are all technical challenges that I think are solvable, but the consent piece, my kids will sell their marketing soul for a points in Starbucks. And so if Starbucks can do it and Target can do that, why can't we as a healthcare system ask permission to mine their social media behavior and figure out when they're getting depressed or when there may be suicide alerts, and mine their shopping behavior and apply those marketing techniques to facilitate health in almost a co-production with their consent, and so it won't work unless it's a partnership in consent.
I agree with that, yep.
One last question, and I know I'm going a little into Chris Kohler's territory in terms of the next panel, but I can't resist because, where you sit, Rob. The Graham Center's research concludes that this is not necessarily about physician-led versus hospital-led, which is some of the earlier research shows, but more about an investment in advanced primary care. So what does that mean for, the ACOs and, what they're facing in terms of how they are incented and the mix of ACOs that are out there, both public and private? I mean, how might this inform how ACOs evolve?
Well, I think that, there's roughly a 50-50 mix between physician ACOs and hospital ACOs. Based on the data that's been out there, as you pointed out earlier, the physician ACOs have tended to get more savings. There are a lot of wonderful hospital-based ACOs that are making the investments in their physicians and primary care. I do have to say, though, that there's sort of a natural conflict. The hospital-based ACOs are conflicted, so you may have the leadership who says we're all in for this managing care and coordinating care and keeping people out of the hospital, and you get the CFO in the room, and he says, what the heck are you talking about, right? And it's tricky. So I think shared savings is a difficult model for a health system that has a lot of hospital assets. Now, what would work conceptually better? Full capitation would work conceptually better, because then you could say, now I have the freedom to start to move the assets around, and I don't have to rely on having people in the inpatient setting. And I think, they're beginning to have that now in Maryland with the global budget models. I think it's very hard to do in practice because of all of the different payers that are out there. Getting them coordinated is virtually impossible. And I think, providers, frankly, most of them haven't had risk, and risk makes them uncomfortable. So I think that's a tough one to sled, but I think there are benefits in both physician and hospital ACOs, and it's in all of our interest to see both of those models succeed.
So bottom line, we have to more radically change the way we pay.
I think, in the long run, absolutely.
Yeah. Okay, on that note, let me please join me in thanking the panelists. ask Chris to come up.
Thanks, Ann. So if members of the next panel could come up, I'll vamp a little bit while you guys are making your way up here. And what about, when's my hook? Our hook? What time? Thank you. And I want to begin with thanks first to Ann and PCPCC for their leadership with this, to Yalda and her colleagues at the Graham Center for putting together a great report, and for IBM Watson. It's great to have you on the team in a continued way with PCPCC, but also supporting the evidence report, and the insights that you folks bring are really important to this. So thanks to all of them. I want to just sort of posit two things at the beginning. One is we're in this room in part because of a commitment to building a primary care-oriented delivery system. We don't quite know what that means, but the evidence is so clear from other places that delivery systems that are built on a strong base of primary care have better population health, lower costs, and are more equitable. A lot of that evidence comes out actually in our journal, the Milbank Quarterly, but I would say we don't quite know what a primary care-oriented delivery system means or how to get there, but it sure sounds good. The second is that for outcome measures, I think the ACA and CMMI got it right. Better population health at equal costs, or better costs at equal population health. Lots of arguments about how to measure it, the benchmark and stuff like that, but the standards that the ACA put forth are good ones for all of us to hold ourselves accountable to. And so we've got this report that talks about the role of primary care in kind of one of our biggest efforts right now around payment reform, which is these accountable delivery systems, and what is the role of advanced primary care. And we're fortunate with this panel, we've got kind of an all-star cast who have people who are actually doing the work to serve. And what I want to have is a little bit of conversation about, does the reality or does the research reflect the reality in terms of what folks are seeing out there? So I want to have a conversation sort of about the reflections on the research, then a little bit about what this means going forward. So just, you all have the bios, but just we've got the provider community represented with Farzad, who is working with Aledade on actually doing accountable care and primary care-based accountable care. We have two payers represented with Mai from Anthem and Ara from the nation's biggest payer, Medicare. And then we've got someone who's both a payer and they're actually representing consumers with the NET from the ERISA Industry Committee, and that's a very important perspective as well. So I'm going to actually go in that batting order, starting with the providers, because we want to get the on-the-ground perspective and say, Farzad, we've got these results that say, Yalda, I'm going to do great injustice, but 6 characteristics to high-performing accountable care from the literature review, and evidence, it's not overwhelming, but that advanced primary care makes a difference. We couldn't quite find a dose response, but it's pretty clear that this measure of advanced primary care, the patient-centered medical home, is a reasonable indicator, or is correlated with, not causal, correlated with better performance on accountable care. So Farzad, you're trying to do this. You're actually beginning with that premise that we want to build this on high-performing primary care. Does this, how does this research that Yalda and her colleagues got inform what you guys are doing?
Yeah, I mean, it makes sense to us. In fact, one of the first things that we do when we look to set up a network of primary care practices in a new location we're now in 23 states. We have set up physician-led accountable care organizations, coming up on 2,000 primary care physicians in those states. A large percentage of ours are folks who are patients at our medical homes. Because I feel like we can start at a higher starting point. We don't have to go through, the 6 things and the importance of access and registries. And there's a lot of the common vocabulary and a way of thinking and a way of kind of orientation that shortcuts it. And also, I think it's important to point out the correlation causation thing because, practices who cared, who were early adopters, who are forward-thinking on patients at a medical home are likely also to be those who are going to be forward-thinking and aggressive and active on payment and care delivery transformation. So that premise that this advanced medical home is a great foundation for taking on the total cost of care accountability makes total sense to me. But I do want to point out 2 things that are different, and where I think, from a provider perspective, the combination of the structures and processes and workflows with stronger 2 things that I think are added into the equation when you talk about combining that with something like an ACO structure. It doesn't have to be ACO, but the 2 key elements here that I think are synergistic. One is total cost of care accountability. That's a big deal. And it runs a little bit counter to the idea that all I should have to worry about is what happens in my 4 walls, right? That, I'm going to do good primary care, but I can't really take on the weight of the whole world. Most of the costs aren't mine. The hospital does their thing. Oh, what can I do, right? So taking on total cost of care accountability moves you from compliance to outcomes in a very real way, in an almost unfair way. Almost unfair, right? Where you're really taking the bull by the horns. And you're saying what matters is, did the patient get hospitalized or not? Not whether I met requirement 1B, access, right? But like at the end of the day, am I reducing the number of ER visits, hospitalizations, total cost of care? So that's one element that I think is really transformative, and it's hard, right? The second is the idea of voluntary alignment of practices choosing to come together in a boat. And they're like, we're in this boat together, and we have shared success. And it follows from number 1. Because if you have total cost of care accountability, you can't do it with your 100 or 200 or 500 or even 1,000 lives. You need a risk pool that is large enough to be able to take on that risk. And so then the question is, who's in my boat? Do I get to pick? Am I just thrown into a big bag and assessed at the regional level, as some have suggested? Or can I voluntarily choose to align with a network of other practices who I know and I trust and I can sit in a room with and I can look in their eyes and we can look at our data together and we can hold each other accountable and we can compete and there's a lead dog and there's, bell cows and, right, like that whole dynamic of the network is incredibly powerful. And we've seen glimpses of this in the QI work and the collaborative work and the beacon communities, right? When they're like, practices come early and they stay late because they want connection. And so those, I think, are the 2 things that I would say are adding to our learning of how do you make effective advanced medical homes to take it to the next level. And then policy is like, how does policy support that, right? Is 1, total cost of care accountability, and 2, connection and networks.
Great. So we got the coalition of the willing that is willing to take this jump into total cost of care. I want to turn to the payers, maybe first with Maya and then with Ara. Back in the dark ages, 5-6 years ago, like the ancient times, there was this big battle between PCMHs and accountable care, and boy, we were threatened by it. And I think a lot of folks hadn't sort of faced up to the music that Farzad was saying that, it's not enough to tick off the boxes. We got to look at this total cost of care thing. But how does this evidence, this research that the Graham Center's produced, reflect kind of the reality that you guys are seeing in terms of working with delivery systems and moving it from primary care or accountable care to something that's a little more integrated?
Yeah, so first of all, I'm really regretting not wearing my bow tie today. Because I think that the folks, and I'm not being facetious at all, I think the folks on the ground hand feel for what this work is like is really an important testament to the face validity of the findings, right? So from the payer perspective, let me just reinforce that to say that, when I look at results like this, I'm a systems gal, and my head immediately goes to systems and to context. And I don't mean health systems necessarily, although they're part of the picture. What I mean is, because this is not a study that, purports to be about an explicit causal relationship, you kind of got to ask, well, what would the nature of the correlation be? And Farzad touched on a couple of those key points, but let me just call it what it is. It's culture. It's culture not just in the bonds between the providers within an organization, it's also the culture that places a primacy on primary care within that organization, because that dictates a whole bunch of very concrete decisions that you make on a day-to-day basis about how you choose to invest your resources, where you allocate your staff, what tasks you prioritize, what investments you make in terms of the kind of technical tools or data tools that you're going to use. It brings a really very different lens to it than if the culture was about optimizing your revenue. Right. So culture, I think, is really important. I think the other thing that's really important that the paper didn't touch on, and Farzad touches on it a little bit, but it's the accountability for total cost of care, and frankly, I think we should expect that whatever relationship the analysis unearthed is likely diluted by the fact that it wasn't able to differentiate precisely what the payment arrangements were that those organizations functioned under. And that if we were able to stratify that and see that a little bit more explicitly in combination with looking at really, you can imagine some metrics for what is the primacy of primary care within your organization, that maybe that dose-response relationship would have popped in a more evident way. And then I think the last point I would make, as not a note of caution or skepticism, but rather as a challenge to the industry, and it echoes some of what was said on the previous panel, is that this is a backward-looking study about what was over the past 4 or 5 years. So let's get real. We are all in this industry playing catch-up to what consumers and patients want, need, and expect. We don't actually deliver healthcare on an app, and that is what they expect. They expect it to be tailored to them. They expect it to be real time. They expect to have no excuses, really, and they expect to have a feedback loop that is in real time. And healthcare as an industry has been very, very slow at catching up to that. So while I think that the results are very affirming of many things, many assumptions that many of us have been working under in designing policies and programs and the shared accountability opportunities for the delivery system, we got to think ahead to what does it mean to be patient-centered primary care delivery vehicle going forward, not back then, and to really think about what that means in terms of stepping up for the providers who are forward-thinking, are first movers, are risk takers. Is it a matter of setting out explicit criteria? Is it a matter of, as the previous panel touched upon, getting actual consumer input? Is it a matter of making the accountability for the patient experience more primary than it is currently? It's often a footnote in many performance scorecards, as you know. And our measuring tools are not great, so let's be honest about that too. But I think that in that constellation, there's nothing in these results that I found surprising or jarring, but it made me want to ask those deeper questions and for us to be honest with ourselves about what it will take to reproduce these results in a more concrete, detailed, and convincing way going forward.
Thank you. How about you, Ari? I mean, Medicare got the ball rolling with comprehensive primary care, with accountable care. Do these results reflect what you guys are seeing up on Security Boulevard?
Yeah, I mean, I think similar to Mai's reaction, there wasn't anything in the report that surprised us. A lot of it sort of affirmed what we had been seeing and have been seeing in our models. I do think that the point that was made earlier about the need to get a better picture of the relationship between ACOs and PCMHs is important, and this report helps bring a little bit of insight into that. And in a similar vein, I think the models like our CPC Plus, where we have a number of primary care practices that are also aligned with shared savings program ACOs, will help add another perspective into that relationship. And we are anxiously awaiting the year one report, which we expect early next year. Are interested in seeing whether some of the synergism that was identified in this report is also sort of showing up in the relationship between those CPC Plus practices that are aligned with our ACOs, and then also looking to see whether there are important differences in terms of the things that are occurring in those aligned practices and the practices that are not. Not all of those CPC Plus practices are aligned with ACOs. We'll have an opportunity to see how they fare, what's different, what's the same. I also think that the report's focus on the things that make ACOs successful is something that also resonates with what we're seeing across our models. And a lot of those characteristics are things that are not unique to ACOs. They are things that are true of a number of different types of value-based arrangements. And so I think it's good to sort of understand that there's that sort of common element, in particular the payer alignment piece. That is something that is very important to us. Our CPC Plus and CPC Classic, its predecessor models, were structured as multi-payer models because we recognize that practices deliver care to their patients in a way that they are going to be more incentivized to change, where the incentives are applicable across multiple payers as opposed to a single payer in the marketplace. And so we continue to build that concept into our models. I think it's an important one that we agree with and that resonates with us, and that is important not just to ACOs, but really across the healthcare transformation spectrum.
So as a recovering regulator, I'm all into the multi-payer stuff, and that's a nice segue to you in it. You guys are our toughest customers, and that you are the most discriminating with your money for the multi-payer stuff. You are the ones who really want to see results to come to the table. I'm speaking about the self-insured industry. So realizing you can't speak for all your members, but in general, are you guys buying what they're selling? Did we get a body of evidence that's persuasive?
Well, absolutely. I think that, first of all, we're delighted to be here. This is critically important to our large employer members. They really are leaders in innovations when it comes to payment models and delivery system reforms. And you're right, they're shameless in demanding high quality, integrated, coordinated, affordable care for their employees. When you think about...
I've had other adjectives at times I wanted to apply them.
But now I have the microphone, so... No, but seriously, I mean, when you think about it, it's really makes a lot of sense. I mean, they're paying 70% on average of the cost of healthcare for their employees, and it's their employees and their families, and they want their employees to be healthy. They're promoting wellness programs amidst a mess from a regulatory perspective. They're trying to ensure that their employees get preventative care and have access to care when and where they need it, which is why they're drivers behind telemedicine and telehealth, generally speaking. And you would think that for our member companies, they have tens, hundreds of thousands of employees. You would think they would be big enough. You would think they could use that heft to go into the communities where they have employees and operations and demand that the providers work with them to create these win-win situations where the employees will get the best care. And they're finding that they're not necessarily big enough. Manufacturers are great examples. When they have a huge concentration of employees, they may not be big enough. But in a lot of cases, the provider groups will say, hospitals in particular, we don't have to do this for other payers, including Medicare. So what we look for are opportunities to align, and we love what CMMI is doing, but let's get Medicare to be as demanding in these communities as the private sector plans, and we really will, I think, drive ourselves to a place where we could ensure that advanced primary care models are adopted all across the country.
Great. So in the time that we have, I want to shift the conversation from the report to sort of talking about its implications in the future. And I want to, from each of your perspectives, think about where we are. Is we've been working on payment reform for a while. The results are not as convincing as people would like, but there are signs of progress. We're learning as we go. We've sort of gotten past the PCMH versus ACO battles and are asking questions like, what's the role of primary care and accountable care? Physicians are saying, okay, right, it's not enough for me to check off the box. I probably got to, or a lot of physicians are traveling the journey that Farzad's talking about to say, I really got to understand that this is about total costs of care because of the concerns of the self-insured. The payers are kind of getting the social determinants of health and things like that. But go forward. What is from your standpoint, kind of the obstacle to progress? I don't want to end on a negative note, but I want to identify what are the things that we should be working on to continue learning, to continue to do right by a country and an economy that's approaching, or an industry that's approaching 1/5 of our economy. What do we got to address? What's at the top of the list? And why don't we just kind of march down, starting with Annette, and go this way?
Okay. I have a really long list, though. I'll try, but top of the list. So, first of all, the public policies have to keep up with the system changes and the design flexibility that employers need. I mentioned wellness programs. You need reasonable regulations that employers can follow so that they could provide these wellness programs to their employees, because we know they work. We need to modernize the rules with respect to high deductible health plans and health savings accounts. They were enacted in 2003. The world is very different since 2003, so that employers can design plans so that employees can have first dollar coverage for chronic disease management and preventive care, and to be able to pay for primary care practices out of their HSAs, or with high deductible health plan money, or with gym memberships and the like. Telemedicine, we need rules across the country where the local medical boards don't prevent the competition from the out-of-state telemedicine providers and the like, and make all of this affordable to employees as well.
So I've been trying to get primary care payments from the payer or the consumer not to be included in the HSA for a while. So that's a great idea. Go ahead. Farzad, what's on your list?
I'm going to highlight two things that I worry a lot about. One is consolidation. If particularly you have hospital physician mergers and acquisitions and consolidation, that's a real threat, I think, to the value-based movement as a whole, and to the kind of engaged autonomy of the kind of advanced primary care homes. The concept being, if you're big, you don't have to be good. And it's a real policy problem. And I think this administration is actually taking a very serious look at it. And things like the facility fee, the site-neutral payment proposal, is a real step, I think, in the let's stop digging the hole deeper direction. But I worry about that. I think employers should be concerned. I think payers should be concerned. I think policymakers should be concerned around maintaining competition in healthcare markets that'll be able to help us drive that forward. And then the second area that I actually think is underappreciated is how difficult it is structurally for payers who are doing kind of administrative services only, or TPAs, for self-insured and self-insured employers to come up with value-based arrangements for that actually work well. It's really hard. You have the small numbers problem where, every self-insured employer has only a small number in every ACO contract. The incentives are around the discounts that people are getting. So, a self-insured employer might see I'm getting PMPM costs taken out, but that's just cost to me. But there isn't really a budget to get savings against. So it's actually in the nuts and bolts of it, it's actually really surprisingly hard. And we have many payer contracts where on the fully insured side, the payer is more than happy to give us a great, shared, gain share, but they're can we carve out the self-insured? And if I'm a self-insured employer, I'm wait a minute, how come I'm being carved out of this? But on the other hand, if I get hit with a line item that says shared savings distribution, I'm hey, wait a minute, why are my costs going? Right. So I actually think that's a really, really meaty, important, interesting kind of TPA 2.0 kind of challenge for payers, providers, and employers to work together on.
Great. How about from Anthem's perspective?
So I've got probably the longest list up here, okay, except her. And I firmly believe in pulling as many of the levers simultaneously as possible. I'm not getting any younger. I just don't have time to do this in a serial fashion, but I will name my top two. One of them is, as a recovering health services researcher, when I see binary analytic results that purport to conclude that some value-based payment construct worked or it didn't work, that binary conclusion really irks me, because what it says to me is some analyst is leaving a ton of data on the table. And what they're leaving on the table is under what circumstances and with whom did it work, and under what circumstances and for whom did it not work, because that is how we improve. So with that perspective, you should not be surprised that Anthem is pivoting from what we believe is the prior era of leave no provider behind in value-based care to a place where we're quite ready to leave some providers behind, because we have learned, no shock to anyone, that not all providers are the same. They are not the same in their culture, they are not the same in their capabilities, they are not the same in their performance. And it is time that we inject more competition into the provider market by differentiating those who truly are high value and have demonstrated that. And we reward them, not just through increased membership and steering of patients, but in as many ways as possible. We reward them with a better business case. We reward them with rewards for most valuable player and most improved player. We reward them with lower administrative burdens. You'll see Anthem doing away with prior auth for high-value providers. So that's one whole massive policy implication, I think, of research like this. It says not all providers are the same, and they shouldn't be treated the same. Because if you treat them all the same, then the people who really went out on a limb and did the hard capital investments and political investments to do this work early and well, why would they stay engaged? The second major implication is the elephant in the room, the set of structural problems that no payer in the land has had the stomach or the fortitude to truly address. Yes, social determinants are among them, and we're really, really glad to see the conversation happening. I think Anthem, like many payers, have been investing in addressing social factors for many, many years, over $300 million in affordable housing, for example, but we haven't done it in a systematic way. Let's put that aside, not because it's not important, but because it's being had as a conversation. What's not being had are the structural distortions in the underlying physician payment system that drive the erection of what is essentially the red brick wall that value-based payment arrangements will run into. Every single value-based payment arrangement in the land, including in MA, is built on the existing physician fee schedule. Not only are the prices overall too high in that fee schedule, but the relative prices are completely distorted relative to input costs, relative to clinical value, relative to utilization trends that would look healthy in any reasonable society. When we don't address that, what happens is there's really only so much that a health system will be willing to invest in primary care or care management. Why? That's not where their revenue comes from, and that's not where their margin comes from. They are very reasonable, rational people. You and I wouldn't do any differently. So let's help them. Let's get the distortions in the fee schedule.
Can I have an amen for fee disruption?
So I think that you will begin to see very concrete action from Anthem in that regard as well.
Okay, she set it up for you.
She did.
Can you wave your magic wand and redo RUC with your...
Not at this moment. It's sort of connected to what Mai was describing in terms of data. I think we have a somewhat difficult needle to thread in that I think what this report highlights is the need for additional data in this space. At the same time, we have been very cognizant of what the earlier panel talked about, clinician burnout, and not wanting to exacerbate that by adding additional data elements, data points for practices, providers to provide to us. But the reality is we need more data, more information in the space. So we will need to think very carefully about how we get those data without also burdening clinicians, adding to their data requirements, increasing clinician burnout. The other barrier challenge I think that we have is limited resources, quite frankly. There are a lot of things that we would love to be able to test. I think there are lots of great ideas I'm sure that you all have that you'd love us to test.
This is where you explain that $10 billion doesn't actually go that far.
Exactly. And that, beyond the funds required to do those models, there are other resources, FTEs, IT resources, that are limited. And so we have to be thoughtful. We have to be selective about those things that we choose to test. And so, looking at a space like this where there's not a lot of data, we don't ourselves in CMMI have a test that really would give you much insight. We need to try to look where there are opportunities to learn. So we've got CPC Plus, where it's a little bit of an inverse relationship. You have primary care plans aligned with ACOs, but maybe there are things we can learn there. Maybe there are things that we can ferret out that are common in both spaces that are true about primary care plans that align themselves with ACOs and the things that those ACOs bring to the primary care plans that enable them to be successful. And piecing together those various pieces of data, get a complete picture to help move the ball forward on this, but also sort of recognizing there is a limit to the number of tests we can run, the number of things we can sort of explore and try to ferret out in our CMMI models.
Great. Well, I think that's a good place. I'm going to hand this off to Ann. I just want to note, just sort of to close this, you've got a really nice representation on this panel of public, private. You've got providers, you've got payers, you've got self-insured. We're being civil. We're talking to one another because there's a common goal that we're working towards. And I would challenge all of us in this room to keep the conversation focused on learning how to do it better, because this is provider payment reform, delivery system reform is a space where we can actually work and learn how to do this stuff better, as opposed to some of the other conversations that are passing around. So please join me in thanking the panel for their work. Peggy O'Kane from NCQA, she gets to raise her hand because she's on my board. So it's in my interest to defer to my board member. Anything you want to add, or did you?
I thought that was a fantastic panel. I want to thank you all for your perspectives. And I'd like to kind of go to the point that's an intersection between Farzad's point about the self-insured employer and to mine. Because as NCQA, we started with fully insured employers who were really vigorously pushing the value agenda, right, in HMOs at the time. And I think it's been much more difficult since we've gone to self-insurance to hold ourselves out in any way as, an answer to their plea for better value for health care. So I wonder, what is the agenda that's needed to, address this point? I mean, we've had this conversation a million times, so please.
Yeah, frankly.
Could you repeat the question? Because I think that the webcast might not have picked it up.
Well, to paraphrase, I think Peggy was asking, what are the strategies going forward to keep self-insured insurers engaged and committed to going down this path?
Value-based payment.
Value-based payment, right. I guess I would say several things. One, that they too are very rational, reasonable people, and they respond to data. And so we are investing in formal evaluations of our programs. And for our new programs going forward, we're going to try to have that be as independent and externally driven as possible. We're also coming up with a mechanism within legal bounds to help ASO clients follow the cash. We actually call it follow the cash. So if you pay into a care coordination fee pool, if you pay into a shared savings pool, we're actually going to show you what happened to your members with that ACO over that year. Will the standard errors be massive? Yes, but we're going to get you our best point estimate, and it is what it is. And so you'll see exactly where that cash came in and where it came out. All that said, we also have the heart-to-heart with them and say, there is strength in numbers. And we have had clients go off and try to do direct contracting with providers, and almost inevitably they come back because it's exhausting. It's exhausting and it's dispiriting, and they find that they don't have the voice that they really should have, even when they have a concentration of their employees at a given health system. So, however, what we also recognize is that, and you should tell me if I'm wrong, Annette, but they often feel like their role is too passive in the entire process. And so we made a commitment in our Go Forward programs, especially with our new high-value network program, that we would co-create it with our most engaged, forward-thinking clients and our providers. It is a pretty uncomfortable exercise, as you can imagine. We're getting to a good place, but, it was rocky for quite a number of months. Why? Because the conversations that needed to be had got had. They got had about what my hopes and desires are. Oh, and then I have to come down to reality. What you can do for me, and then you have to come down to reality. And what are those trade-offs that we're willing to make? Are we really willing to go to narrow network? Are we really willing to steer our members? Are we really willing to go to downside risk? Are we really, 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 really? I think that's how ASO employers feel empowered, is they have a seat at the table. We talk about activating patients and being patient-centered. Well, we serve multiple stakeholders, and our clients in many ways are the best proxies that we have for our members. So we get direct member engagement where we can, but it is really important to us that there be as few surprises by the time a program rolls out as possible, so that their fingerprints are all over it.
So we've got some time for some questions and answers. I would ask folks to line up behind the mic so that folks on the web can hear it. And while you're deciding who wants to go up and stand in line, I just want to ask Annette, as kind of a follow-up to that. What is all of us who are working on all this good stuff, multi-payer payment reform, quality measures, the things that Peggy's talking about, give us advice about how to get self-insured folks to show up, to be at the table, to participate in the co-creation that Mai's talking about. Be a whisperer for the self-insured. How can we help them, get them to the table?
For my member companies, which are, all very large, they're not shy at all about demanding a seat at the table. So I think that they need to see that there is alignment of interests in ensuring that people will be creative to get the access to the care and the best quality providers for the employed population. I'm not sure that, maybe I'm not understanding your question.
Let me press this a little bit. What if the table is local and Bank of America is a national self-insured? So Bank of America, and I'm just picking on them, it could be any of your members. They want a national table. Farzad's Anthem, they're engaged in local conversations because you know what, Vermont is pretty different from Texas. So what if the table's local, but the self-insured folks want these national conversations?
Well, I think our members recognize that the conversation has to be on a variety of different levels, because you can't, while we are pleased that we have one set of regulations to follow on the federal level, we recognize that care is provided in communities across the country, and that we need to have solutions that employers can tailor to work in the communities across the country. So, and they work in on the local level to ensure that the networks are correct and things like that. But it is difficult which is why we partner with organizations like Anthem to be able to craft something nationally, but that works in the communities. And I think one of the worst things that happens now are states and localities trying to get involved in saying, well, let's figure out what the self-insured organizations are doing, and let's see if we can tax them or regulate them or mandate how they should do things in our community for various industries or types of companies. That's the worst thing that can happen. I think that the best thing for the self-insured market is to give us the freedom to design what works for our employees across the country as well as in the communities in which they live and work.
And I just want to put a pin in this conversation because this local national dynamic is really important. It's what we're learning in CPC Plus, is that the conversation in Arkansas is just different from the conversation in Oregon. And it's hard for you, but frankly it's hard for CMMI, for Medicare to track all these local conversations, figure out when are they flexible, when do they say, nope, this is the way it's going to be. And Anthem's got the same issue. Whereas locals are like, hey, do it all our way, because we know what works in Little Rock. So
that's why centers of excellence are so important as you think about the initiatives that a self-insured employer can adopt.
Please, and introduce yourself.
Sure. Alyssa Crawford from Mathematica Policy Research, so a not recovering health systems researcher. And I don't want to take away from the conversation about systems, because I think that is really where the value will happen and where we can really move the needle in more meaningful ways. But I want to talk a little more pragmatically about on the ground, because as all of these larger changes and larger discussions are happening, providers and systems still need to understand where they can move the needle and where they have opportunities to both improve improve quality and lower costs. So can you talk a bit about the opportunities we see, not just specifically to adoption of PCMH, which is clearly a piece of the picture, but about identifying the right opportunities to improve quality and to just generally adjust the way that they're providing care for patients, either through stratification or through different types of initiatives or health IT that can make their, sort of quadruple aim goals a reality?
Maybe you want to take a whack at that? Farzad, you look like you're
I'm trying to figure out at what level to address that. I'll take one slice at it, but I think there's many ways to go with that question. Identification of opportunities, right? Like it's a target-rich environment. So what's the rubric? What's the framework for deciding how you prioritize? I think is super, super important and interesting. And one of the best things about working in New York City between 2002 and 2009 was we had a really crystal clear mission of how do we save the most lives in the health department, right? And it was like, ding, like that just, and we're like, okay, well then let's start with smoking, and then we do blood pressure control, and right, you could just rack and stack because you had a very, very, very clear framework of what are you trying to do. So to me now it's a little bit different. Now it's like, how do we prevent the most hospitalizations, right? And then that creates the structure for this. But of course you got to balance short-term, long-term. You got to think about, creating sustainability in your savings, so you can't only do, high risk management or transitional care management or whatever. You have to create this portfolio. But the single hardest thing that we do day in, day out is prioritize and say, we're not going to try to do everything but this practice. If there's going to be one thing you do today, if there's going to be 10 patients you call today, what's it going to be? So that prioritization is really, really hard, but it helps to have a framework.
Yeah, I would definitely echo that, and I would say there isn't one right answer. It has to be right sized to the clinical organization. So there are some organizations that are going to be resourced enough to really go after that top 5%. There are other organizations who are going to feel, you know what, we can't box above our weight. What we can really do is focus on referral management, or we can focus on, these two chronic conditions and do those really well. As far as that said, it's a target-rich environment, and there are multiple paths to get there. One of my pet fantasies was always for some entrepreneur to set up sort of a Yelp/Match.com mechanism for providers doing this work, where they could upload the things they've tried and rate how well they work for them, and then you could search for those reviews, if you will, based on the type of organization it was. Because I don't know that, for Farzad's organization, it makes sense to look at what UCSF is doing, but it might make sense to see what a successful IPA in upstate New York is doing. There's a lot of learning that could be happening that is happening way slower than it should be. There isn't a one answer.
And I would just add to that, from the Innovation Center perspective, I think we are very consciously trying to add to that target-rich environment with a number of different options for clinicians. So recognizing that all clinicians are not at the same place, don't have the same capacity for taking on risk, haven't moved as far along on the transformation line as their counterparts may have. And so we want to make sure that there are options available for a number of different clinicians, whether you're talking about specialties, level of experience, appetite for risk. And so we are constantly looking across our portfolio of models, assessing where there are gaps, opportunities to create additional opportunities to meet specific needs, small providers, rural providers, some specialties, and also looking at patient populations, like thinking about whether there are opportunities to create models around patient populations that aren't currently included in one of our models. So I think to Farzad's point, just, there are lots of different options. We're trying to be very conscientious about creating opportunities, and are interested in hearing about places where we might think about creating models that we haven't currently gone.
Thank you. Next. Well, why don't we go back to this first point line? Yeah.
Thanks. I'm Eva Powell with the Alliance of Community Health Plans, and my question has to do with what seems to me sometimes to be a bit of an outsized focus on the cost of care part of the value equation, and how do we right-size the quality portion of that equation? I think the panel has been wonderful, and you've addressed a few of those ways in terms of the systemic barriers, but I'd love to know other ways that we can give this report legs, particularly in the ACO model that seems to have such great promise, which is evidenced by the report, but I've seen a number of occasions where it has really stymied some of the very things the model is there to advance, because ultimately, in the end of the day, in the boardroom with the CFO, it comes down to the balance sheet and the cost of care.
There are lots of ways to potentially answer that question. So we don't think about cost without thinking about quality. I don't know how to separate those two in my head. It's not that I think they're always linearly correlated. I just think that you can't think about them separately. You're trying to optimize the performance of the system, period. That said, concretely, our go-forward approach to performance measurement and accountability for clinical quality and patient experience has been twofold. One, we are moving dramatically away from a world of believing that there is more accountability the more metrics that you have. We are moving for our most advanced providers to literally 8 to 10 metrics, all outcomes, not a single process among them, and patient experience. That's it, you're done. If you're taking downside and you've got all this other stuff going on, what do I care what process you're doing? Just get me the outcomes, please. So we can't be any clearer. It's not that we're, and we're even letting them pick the 8 to 10. We're saying, here's a menu of 30. You and your market, you guys get together, you figure out what's important for Indianapolis or, Denver. And then we're content. And we have a story that we can tell both our members and our clients. They understand outcomes metrics. It's the process ones that are hard to explain. And I think it really burns the fat from the mind of the providers because, we're clinicians. There is nothing that gets our blood boiling faster than a threat to the well-being of our patients. So you tell us that's our job and you free us up to do that, we're happy. And that's what we want to offer them is to get this make work stuff out of the way.
Let me get one more question, and then I think I'm going to get the hook from Ann. Please.
Katie Capps with Health 2 Resources. And this question is to CMS, and it's to the ERISA Industry Committee, because from the standpoint and the role as buyers of healthcare, I'd be interested in hearing your perspective, because there's a lot of innovation occurring in the market right now. Sometimes that's a result of dissatisfaction with products and services out there, and sometimes it's a result of piloting things that have worked and you want to scale it up. I'd be very interested in both of your perspectives from a public payer standpoint as a buyer and from a private sector payer standpoint as a buyer of what you perceive to be the top 3 things you need from the delivery system that will create what your members in your situation or your beneficiaries in your situation need, want, and desire.
Do you want me to?
Top 3.
Top 3. So I think choice is at the top of the list for, you're talking about beneficiaries, what they need, what they want. I think definitely options that have an eye to the sort of local flavor, so not a one-size-fits-all approach, but with some attention to the particular needs in a region. And I also think maybe sort of wrapped into that, an eye towards needs for special populations. And maybe just, I think maybe just those 2 are the things that sort of come top of mind. They want transparency. Maybe I'll add that one into my top 3, transparency. And that is sort of a broad theme. It is transparency in terms of price. It's transparency in terms of their data, maybe a little bit of access woven in there too. It's transparency in terms of sort of the access to the healthcare system, the healthcare process, being a participant in it as opposed to an observer or recipient of the services. So I think trying to blend all of those things in a way that makes sense for the patient and in a way that is operational for us are the things that make models attractive. I will, though, add in there that our other stakeholder, not to be ignored, are the providers, right? They are the ones who are delivering care through our models, and so their needs also need to be a part of that equation.
Annette?
I would say, I would say that flexibility from the perspective of being able to design things that work best for whoever it is that we're buying services for. Certainly, transparency couldn't echo that strongly enough to know what it is that we're buying, does it work, how much does it really cost, et cetera. And I think I would just say the word alignment. I think that if everyone is focused on the same things, improved access to high-quality, integrated, coordinated care at affordable costs, if all providers, all payers are interested in that, if the providers are on the same page, and the consumers who aren't necessarily the purchasers all focused on that same thing, I think that alignment would really move the needle in a big way.
Great. So on that note of alignment, remember what aligns us here is this learning about the role of advanced primary care in the kind of goals that the folks have listed here. And that's what the PCPCC is all about. And on behalf of the fund, we're pleased to support that learning around how do we build a high-performing primary care-based delivery system. So please join me in thanking these panel. They've been great.
So I'm going to close out our program, but first, please join me in thanking all of the panelists from YALDA who relayed the research findings in the Graham Center that the Graham Center produced, and also our first panel that looked at patient and clinician views of what this research might mean and implications, and this last panel. I'm going to try to underscore the major themes that we heard this morning, and you may have your own version of that, and I'd be interested for you to add that after the panel. We'll be here for a while drinking coffee, and please stay and continue the conversation. I mean, I think we heard right off the bat that Mai said these research findings have a lot of face validity, and that was really reinforced by Ara, who basically said, yes, these findings seem to reflect what we're finding at CMMI, and yet we need to do a lot more research to study this relationship between these two models of care that do not exist in separate islands. I mean, obviously they are in the same ecosystem, and so how do they work together? And in fact, Ara suggested that maybe there are things that they can do with their data and with their model to really look at this relationship. So we would welcome that. I think we also heard from both Mai and Farzad that culture really matters, and that culture that is embodied in how do the clinicians interact with each other and the bonds that they have in terms of communication and integration, and are they actually functioning to deliver the care around the patient. So what is this about the culture? We also heard from Mai that does the patient-centered medical home or the ACO put a primacy on primary care? Because it is what you value and where you invest. And then we also heard from Mai that the current system is incredibly distorted, that it is not valuing, in her view, and I think in the view of many, including the PCPCC, it is not reflecting what we think the health system should value. It's quite distorted. And she also was very provocative in saying that Anthem is going to incent and invest in those providers that are really trying to embody the values that Anthem sees to deliver better health. And that is really, I think, reflected in primary care and many other aspects of the health system. Over and over again, we kept returning to this whole theme of payment, and this came up, in many, many different ways. Farzad really made the case that we need to have the entire system focused on accountability for total cost of care, and that really, Maya said she was talking about removing the fat from the brain. I wasn't quite sure I understood that analogy, but right, thank you. Focuses the attention on some really important outcomes, and also said they were going to try to get to a very small number of outcomes that the providers they contract with will relate to. We heard from Rob Mechanic about, we really need to move much more rapidly to capitation so that we can really dispel these conflicting incentives that exist. We heard from Annette in terms of other payment issues that HSAs should expand the safe harbor to incent primary care and chronic care management. We're working on that policy issue. We completely agree, and we think it might help to address some of the issues with the decline in primary care visits, because I think HSAs may be having an effect here, as are other ways we've structured benefits. And we heard finally about, and not finally, but actually throughout the entire program, about the importance of being more focused on what patients' needs are, and that there is no one patient, and that we need to consider how to stratify patients so we can best respond to their needs, that they're not all created alike. The 20-somethings different than the frail elderly. And that technology, Bill mentioned that technology can help us to do that. There's sort of the basic blocking and tackling and the importance of a registry, but then there's much more advanced things that we could do to get to a sophisticated view of what patients need. Precision medicine, data from wearables, AI, et cetera, but that we need user-centered design so that providers are not faced with yet another barrage of data. And because we already have a lot of burnout across all clinicians, and particularly in primary care. And then finally, I think we heard that with all of these models, there are some important cross-cutting themes that patients are looking for. Absolutely access, care coordination and integration, and perhaps most importantly and often overlooked and very difficult to quantify, it's that relationship between the patient and the clinician, the physician, the nurse practitioner, that is really going to help guide you through whatever your health issue is, understand you in a comprehensive way, relate to you as a whole person and not just a body part, and how important that really is in the care transformation work that we're all trying to achieve, that we cannot undermine that relationship. In fact, we need to build it up more. We hope that these findings will influence the folks at CMMI as they evolve their models. We're so pleased to have a number of CMMI leadership here with us today. We've not, in addition to Ara, Pauline is with us, and as is Michael, thank you. I'm looking for your name, and I'm sorry, I just missed that. So we're really pleased to have CMMI here. The private payers, in addition to Anthem, the employers, and the consumer organizations. We want to thank, in particular, the PCPCC board. Darrell is representative of that. It is a wonderfully committed, mission-driven board that always puts the patient first. To our sponsors, Milbank, Watson Health, IBM, NCQA, Pacific Business Group on Health, AAFP, Pacific Business Group on Health. Really, we could not have done it with all of you. Thank you again for your support, and so pleased that you could all be here today.